Hello, friends. A very good evening to all of you. Please confirm if I'm audible and if my screen is visible. Yeah, good evening. Hi, Tracker and Vibes. Dolly. A very good evening to all of you. Today we will be discussing some very important topics for the upcoming FMG exam. So, we'll be discussing pediatrics in two parts. We'll be discussing the general pediatrics part today and the important topics from neonatology and systemic pediatrics tomorrow. So, the timing for tomorrow's session would most probably be 5:15 p.m. The link for tomorrow's session has been shared in the description of this video. Okay. We will be discussing basically this will be a quick revision of the very important topics from general pediatrics, which are must know areas for you. And I want this session to be an interactive one, and please do answer the questions, and of course we will be discussing the important things quickly as we go, right? So let's start. Starting with the important developmental milestones. So we all know, the important developmental milestones are divided into four domains. So what are they? So the developmental milestones, just give me a moment, please. I'll just open it in. Yes. So the important developmental milestones we know can be divided into gross motor, fine motor, social, and language milestones, right? So the developmental milestones, we'll be discussing the important ones in each of the domains. So starting with the gross motor. So we all know, when does neck control come? So neck control comes usually, partial neck control appears by 3 months of age, but complete neck control appears by almost 5 months of age, right? Then, sitting, standing, walking will come in that sequence. Everything will come with support first, without support later, right? So sitting with support comes at around 6 months of age, and that is, sitting in tripod position with the support of his or her own hands. You can get a picture based MCQ where a child is taking the support of his hands and leaning forward and sitting, right? Sitting without support would come at around 8 months of age. Standing with support will come at around 9 months of age. So very easy to remember the sequence, right? Creeping would come around 10 to 11 months of age. Standing without support would come at around 12 months of age. Walking with support or walking with one hand held also comes at around that time, so around 12 months of age. Walking without support around 13 months of age. And when is a child able to ride a tricycle? Yes. Come on, tell me. Yes, so when is a child able to ride a tricycle? A very important, must know milestone which you must remember. Very good. So at 3 years of age, a child is able to ride a tricycle. So we all know a tricycle has three wheels. So riding a tricycle at 3 years of age. Very good, right? So good. Unnati, Shreya, Akansha, Fuzail, MS, Debopam, Karishma, Nikhil, Niger. Okay. So moving ahead to the important fine motor milestones. So when does hand regard come? So hand regard is a milestone where a child brings his or her hands in midline, and as if the child is examining or looking at his or her own hands. Okay. So this hand regard usually comes at around 3 months of age. Bidextrous grasp, that means grasping using both hands. Okay. So that will come at around 5 months of age. Okay. 4 to 5 months. It is a bit of an ambiguous area. So 4 to 5 months of age, this bidextrous grasp comes. Palmar grasp or unidextrous grasp comes at around 6 months of age. A child is able to transfer objects like this. So this has been asked in a question previously. So transfers objects by around 7 months of age, right? Then immature pincer grasp, we all know, around 9 months of age. Mature pincer grasp, 12 months. The child is able to scribble spontaneously like this. So that will come at around 15 months of age. Building a tower of 6 to 7 cubes at around 2 years of age. Number of cubes put in tower is age into 3. So 2 years, tower of 6 cubes. 3 years, tower of 9 cubes, and so on, right? Handedness, handedness, that means the child will have a preference for one particular hand. So this handedness appears by around 24 months or 3 or 2 years, but it gets established by 36 months or 3 years. So the handedness gets established by 3 years of age. Okay. So that is an important milestone. Okay. So moving ahead to the drawing skills of a child. So drawing skills of a child, we all know the child is able to copy a straight line. So a line has got two ends, right? Two ends. So copying a straight line comes at around 2 years of age, right? Now the number 3 has this circular thing here. So copying a circle comes at 3 years of age, right? A rectangle has got 4 vertices. So copying a rectangle, very easy, comes at 4 years of age, right? And finally, copying a triangle comes at around 5 years of age. So that is how you can very easily remember the drawing skills of a child, right? So moving ahead to important social milestones, social smile comes at around 2 to 3 months of age, right? Mirror play comes at around 6 months of age. Child looks at his or her own mirror image and tries to play with it. Stranger anxiety around 7 months of age. Waving bye bye is a very important milestone. When does it come? Yes, waves bye bye. When does it come? Anyone? Waiting for your answers? Waving bye bye. Very, very important milestone. Vishal, very good. Vishal, Niger, Sneha, Aryan, Nupur, Unnati, Ranveer, Rituraj, Shreya, very good. High tracker, Kajal, right? Rachna, okay. So, Dr. Ramesh. So, 9 months. Waves bye bye at 9 months. Plays peekaboo, okay? Hiding his face and uncovering, and that comes at around 10 months. Plays a simple ball game at around 1 year of age. Points to objects, okay? So, points to objects comes at around 15 months of age. Domestic mimicry comes at 18 months. Dry during daytime again at 18 months. Parallel play comes at around 2 years of age and joins in play by 3 years of age. So these are the important social milestones. Moving on to language milestones, a child vocalizes or produces some sound by 2 months, cooing by around 3 months, monosyllabic babbling like ma, ba, da around 6 months of age, bisyllabic babbling at 9 months, 2 to 3 words with meaning at 1 year of age. Remember 1, 2, 3. So at 1 year, 2 to 3 words with meaning. Jargon speech, that means using their own particular names for different objects, indigenous names. So that comes around 15 months of age. 10 words with meaning. A child is able to speak 10 words with meaning at around 18 months of age. 2-word sentences. So remember, the number of words put in sentences is approximately equal to age in years. So 2-word sentences at 2 years of age, 3-word sentences at 3 years of age, and so on. And the child is able to, tell a story or a poem or sing a song by around 4 years of age, right? So, let us see some quick questions which you should be able to solve with this knowledge of developmental milestones. So, which of the following statements are true? First, hand-to-hand transfer appears, then palmar reflex disappears. So, there are certain primitive reflexes, they disappear and then the milestones appear. Like, voluntary grasp of objects, and thereafter, the unidextrous grasp and transferring objects, they all will come only after the palmar grasp reflex is lost, which is lost at around 3 months of age. So first hand-to-hand transfer appears, then palmar grasp reflex appears is wrong. Okay. So let us see if someone has answered it correctly first. Right. So Amritan, Shreya, Gajender, Samshed, Dr. Sarika, Sandeep, Aryan. Very good. Awesome, guys. Manzar, Unnati. Manzar's answer is not right, I'm afraid. Okay. But most of you have answered it correctly. Right. So first palmar reflex disappears, then hand-to-hand transfer appears is the correct answer, because once palmar reflex will disappear, only then voluntary grasp will appear, and then this unidextrous grasp will then appear, and then transferring objects from one hand to another is going to appear, right? Okay. So both palmar reflex and hand to hand transfer appear at the same time? No. Both disappear at the same time? No. So the best answer is B, right? So moving ahead, when does handedness get established? So this, of course, we've discussed right now. So waiting for your answers, quick. So it's a rapid fire. Come on. So when does handedness get established? Let's see your answers. Quick, quick, quick. So yes, Alia, Nupur, Dr. Rain, Vishal. So yes, 36 to 40 months. So this is how simply these important milestones you can try to remember in the form of a story, and you remember the logical sequence in which they will come, and some of the important milestones which we discussed, you have to remember the times at which they come. There's no shortcut to it, but once you go through it a couple of times, so if you keep on try to read the milestones for early in the morning, say once you read them, just read them once, okay, every day for next 7 days, and I'm sure you'll definitely remember them, right? Even next 3 days would do, okay, but try to remember it like a story and the logical sequence in which they should come. Okay, so moving on to some quick facts about dentition. How does teeth appear? So primary dentition, secondary dentition. What do you mean by primary dentition? So primary dentition is also known as milk teeth, we all know. Secondary dentition is also known as permanent teeth, right? Permanent teeth. So when does the primary, so this table will help us solve so many questions related to dentition. So primary dentition, or the first tooth to appears at around 6 to 7 months of age, while secondary dentition begins at around 6 years of age. The first milk tooth to appear or first tooth to appear in a child is the very important. So it is the lower central incisor. While the first permanent tooth to appear in a child is the first molar. Okay, first molar. The last milk tooth to appear in a child is the second molar, while the last permanent tooth to appear in the child is a third molar or the wisdom tooth, which might not appear in some of us also, right? The primary dentition would complete at around 2.5 to 3 years of age, while secondary dentition would complete by around 12 years, except of course the third molars. So third molars come anytime, between 18 to 25 years of age and may not erupt in some also. So 12 years except the third molar. And total number of teeth in primary dentition is 20, while in secondary dentition it is 28 to 32, depending on how many permanent molars or third molars have come, right? So now, quickly, which is the first tooth to appear in a child? We all know which is the first tooth to appear in a child. What's the correct answer? Come on, quick. Right? Very good. Nupur, Alia, Vinay, Aditya, Mohammad Rafiq, Ranveer. Very good. So it's the lower central incisor. What is the number of primary teeth in a 3-year-old child? So in a 3-year-old child, we know all the milk tooth would have erupted by then. So what will be the total number of teeth in this child? So again, the answer is going to be A, that is 20, right? Now, moving on to some quick facts about breast milk and breastfeeding. So what do you mean by exclusive breastfeeding? So exclusive breastfeeding means the baby should be on breast milk and nothing else, not even sips of water unless medically indicated. So exclusive breastfeeding is recommended till 6 months of age. Okay. What are the signs of adequate breastfeeding? So you can get a case scenario where the mother is feeling that the child is still hungry, or her milk is not adequate. So what are the signs of adequate breastfeeding that you can elicit from the given case scenario or given history? So if there is adequate breastfeeding, what will happen? The child will sleep properly after taking a feed for 2 to 3 hours. The child will pass urine at least for 6 to 8 times a day. Okay. And the child will gain weight. So those are the signs of adequate breastfeeding. Gaining weight, sleeping peacefully after taking a feed for at least 2 to 3 hours, and passing urine 6 to 8 times a day, right? So those are the signs of adequate breastfeeding. Now, what are the contraindications to breastfeeding? So there are some contraindications related to baby, some contraindications related to mother. Very important. So related to baby, if it is a confirmed case of galactosemia, okay, galactosemia, the baby is not able to digest lactose. Lactose contains glucose and galactose. So galactosemia, breastfeeding is contraindicated. Any form of milk for that matter is contraindicated in galactosemia. Okay, so you have to use lactose-free formulas. And if the baby has congenital lactose intolerance, okay, congenital lactose intolerance, very good. I can see some of you already answering it. Very good. Okay. Now, absolute contraindications related to the mother would be where if the mother is on chemotherapy or radiotherapy due to some malignancy. If the mother is on chemotherapy or radiotherapy, that is an absolute contraindication to breastfeeding. And some relative contraindications are like some infective conditions in the mother where you may or may not breastfeed depending on the exact scenario. Like, if there is maternal HIV or maternal untreated TB, tuberculosis, okay, untreated TB, okay, or if mother has, lesions of chicken pox involving the breast and nipple area especially, okay, or if there is breast abscess. So these are some relative contraindications where you may or may not breastfeed depending on the exact situation, right? The composition of breast milk again is very important, guys, and its comparison with cow's milk. Multiple times you've got questions related to that. So quickly brushing over it. So, carbohydrates, we know the lactose content in breast milk is more than cow's milk. So breast milk has a lactose content of around 7 gram per dl versus 4.5 gram per dl in cow's milk, right? So breast milk gives more energy as lactose to the baby, right? Now, about the proteins, if you ask me, breast milk has lesser protein than the cow's milk. So breast milk has a protein content of around 1 gram per dl versus 3.5 gram per dl in cow's milk, okay? So, and the breast milk is richer in whey proteins like lactalbumin and lactoglobulin, which are more easily digestible than casein in cow's milk, okay? So, richer in whey proteins like lactalbumin, lactoglobulin, and so on, right? Okay? And the breast milk contains adequate amounts of, amino acids like cysteine, taurine, methionine, which are required for the CNS development of the baby, right? So that is about the proteins. If you talk about lipids, breast milk is richer in PUFA, polyunsaturated fatty acid, which are beneficial for the baby. Okay, richer in PUFA. And breast milk also contains adequate amount of DHA, that is docosahexaenoic acid, again, which is required for the CNS development of baby. Okay, so DHA is high in breast milk, right? If you talk about minerals, the calcium phosphate ratio in breast milk is such that it favors calcium absorption. However, if a baby is exclusively cow milk fed, more chances of having, calcium deficiency and rickets and so on, right? So calcium absorption is better in breast milk. Though breast milk is not very rich in iron, but the iron present in breast milk is also more easily absorbable. Okay. And what about the vitamins? So vitamins, breast milk, very, very important. Multiple times it has been asked. Breast milk contains adequate amount of all the vitamins except, okay, except vitamin D, vitamin K, and vitamin B12 in strictly vegan mothers. Very, very important. So because breast milk is deficient in this, it is recommended all the babies in the first year of life should be given vitamin D supplementation. Vitamin K 1 milligram intramuscularly should be given to all babies at birth to prevent what? Yes, to prevent hemorrhagic disease of newborn, now called vitamin K deficiency bleeding, right? And vitamin B12 is deficient in strictly vegan mothers, in the breast milk of strictly vegan mothers, right? What is colostrum? So friends, we know the colostrum is the milk that comes in the first 72 hours after birth, okay? First 72 hours after birth, and it is thick and yellowish, and it must be fed to the baby. It should not be discarded. It should be fed to the baby because it is rich in IgA, okay, rich in IgA, macrophages, proteins, okay, rich in IgA, macrophages and proteins. So it is so important to develop, the immunity of the baby, that it is also called the first immunization for the baby. Okay, it is often referred to as the first immunization for the baby, right? But it is poorer in lactose, okay? So poorer in sugar or lactose, it is not very tasty for the baby, but it is very, very, important and beneficial for the baby, right? Now, some quick questions. So, all are signs of adequate breastfeeding in a 2-month-old infant except. So, what do you think is the answer? A. Baby sleeps for 2 to 3 hours after feeding. B. Baby urinates 6 to 8 times per day. C. Baby gains weight. And D. Baby has normal hemoglobin level. Right? So don't miss the word except in the question. Read the question very, very carefully, guys, wherever there's a except, okay? And always, always read all the 4 options before answering the question. Don't jump on to answer a question before, going through all of the options, because you might realize first is also correct, second is also correct, third is also correct, and you would have missed the word except in the question, right? So yes, so let us see. ASGL, Soumya, Mohammed Shabaz, Akansha, Kamakshi, Dr. Ramesh, Kabir, Ranveer, Dr. Rain, Dr. Yuhi, Bansir, High Tracker, very good. So D is the best answer, because we all know that adequacy of breastfeeding is indicated by the first 3 points. Okay. Right. Moving ahead. Breast milk should be continued for minimum how many months? So we all know breastfeeding, exclusive breastfeeding is recommended for what age, till what age, we all already discussed. So yes. So even if, yes. Okay, very good. So 6 months, A is the correct answer. So exclusive breastfeeding is recommended for 6 months, and after 6 months, what is started? Complementary feeding. Previously, it was called weaning, but now it is called complementary feeding. Okay, so complementary feeding is started after that. And sometimes if the mother is working, express breast milk is taken, and express breast milk can be stored also. So you get questions related to the storage of express breast milk also. So at room temperature, we all know it can be stored for 8 to 10 hours, right? In a refrigerator at 2 to 8 degrees Celsius, it can be stored for 24 hours. And in a deep freezer at minus 20 degrees Celsius, it can be even stored till 3 months. So that is also very important, has been asked previously, right? Now, all are true about human colostrum except. Yes, what is the answer? So, thick and yellow color, IgA high, high amino acids and minerals, and high sugar. So, what is the correct answer? All are true about the human colostrum except. Yes, very good. So, D. D, high sugar, yes. So, sugar is not high in colostrum. Rest of all are correct, right? So, absolute contraindication to breastfeeding out of the given options: galactosemia in the infant, maternal hepatitis C, maternal CMV, herpes not involving the breast. Yes, so what is the best answer? Absolute contraindication to breastfeeding. So, we already discussed. So, it is very good. A. Ayushi, Shalini, Gajendra, Akhtar, Shamshad, Bensir, Rachna, very good. So if there is galactosemia in the infant, of course, we are not going to breastfeed. Okay, this is one of the very few conditions where breastfeeding is absolutely contraindicated in the baby. Okay, maternal hepatitis C, CMV, herpes not involving the breast. So in these conditions, you may, breastfeeding is not increasing the risk of transmission to the baby. So you might as well breastfeed. Okay. Nutrient deficient in breast milk, vitamin A, B, C, D. Again, very, very easy. So we all know breast milk contains adequate amount of all the vitamins except. Yes. So we discussed. Very good. So vitamin D. So, pyloric stenosis, one of you asked about IHPS. So, pyloric stenosis is not a contraindication for breastfeeding. Okay, breastfeeding can still be done. But of course, you have to, tackle the problem, and if surgery and all might be indicated for the treatment of the condition, right? Okay. So, vitamin D is the best answer here. And we also know vitamin K is also deficient. Now, moving on to a little bit about malnutrition. WHO classification of malnutrition, very, very important. So it takes into account weight for height, height for age, and whether edema is present or not. If edema is present, the category is called edematous. Okay, edematous. Right? Now, weight for height. If the weight for height is between -2 to -3 Z score or 70 to 79% of expected, what is it called? Anyone? Yes, what is it called? Come on, waiting for your answers. Weight for height between -2 to -3 Z score or between 70 to 79% of expected. Very good, Kiran. Song edit, nice name. Vishal, Sanjay Kumar Patnayak, Dharamvi, no, not the Kwashiorkar, dear. So, Akhil Raj, Ankit, okay. So, it is called wasting, okay. So, weight for height, remember it is weight for height and not weight for age, okay. Weight for height between -2 to -3 Z score or between 70 to 79% of expected is called wasting. Less than -3 Z score, less than 70% of expected is called severe wasting. Okay, severe wasting, right? Height for age again between -2 to -3 Z score or between 85 to 89% of expected is called stunting. Okay, stunting. While it is, if it is less than -3 Z score, less than 85% of expected, it is severe stunting. Okay, so that is the WHO classification of malnutrition. Very good. Okay. So moving ahead to a Wellcome Trust classification. So this gives us very important terminologies which are often asked in your MCQs. So if the weight for age, so remember here there is weight for age. Okay, in the WHO classification it was weight for height. So weight for age and edema are taken into account. So if the weight for age is between 60 to 80% of expected and edema is not there, it is just called undernutrition. Okay, no special name for this, it is undernutrition. But if the weight for age is between 60 to 80% of expected and edema is present, what is it called? Yes, who can tell me? Weight for age between 60 to 80% of expected and edema present. What is it called? Yes? Come on, waiting for your answers. So if vitamin D and K both are present, then vitamin K would be a better answer for the breast milk, which vitamin is deficient in breast milk. Because, vitamin K is a must 1 milligram intramuscularly should be given to all babies at birth. Okay. So vitamin K definitely would be the answer if you have to choose between vitamin D and K. But in most of the conditions, vitamin D is also, is usually deficient in breast milk, right? So yes, Kani, Dhananjay, Rajendra, Manzar, Benazir, Kwashiorkar is the correct answer. So weight for age between 60 to 80% of expected with edema. So it is believed that protein is more deficient than calories in these children. Okay, so it is a deficiency of protein as well as calories. Okay, protein energy malnutrition. It is a Kwashiorkar if edema is present. Right? If the weight for age is less than 60% of expected but edema is absent, then it is called marasmus, where the child is, very, very emaciated kind of appearance. There is no edema. Okay. But if the weight for age is less than 60% of expected, that means it is just like marasmus, but edema is also present. So some characteristics of Kwashiorkor, some of marasmus. Then it is called marasmic Kwashiorkor. Okay, marasmic Kwashiorkor. Right? Now moving ahead to another very, very important topic, definition of SAM or severe acute malnutrition. Very, very important, right? So how do you define it? So in a child between 6 months to 5 years of age, SAM or severe acute malnutrition is defined as presence of one or more of following. So what are they? So weight for height less than 70% of expected or less than -3 Z score. Okay, that is one. Okay. Mid-arm circumference or mid-upper arm circumference less than 11.5 centimeters. Okay. Or presence of symmetric bipedal edema of nutritional origin. That means the child is having edema and there is no other reason for edema. Like there's no nephrotic syndrome or cirrhosis of liver or anything else. So symmetric bipedal edema of nutritional origin. So if any of these is present in a child between 6 months to 5 years of age, we label it as SAM or severe acute malnutrition. Okay, very important, guys. Now, moving on to some quick questions. A 3-year-old child presented to OPD with mother. His mother reports normal breastfeeding till 2 years of age. Now the child has decreased milk intake. On examination, malnutrition was found along with edema. What is the diagnosis? So malnutrition along with edema. We all know what is the terminology used for that. So malnutrition with edema, is it kwashiorkor or marasmus or wasting or stunting? Waiting for your answers. Yes. Aryan, Pavan, Shashi, Aditya, Debopam, Vishnu, Hansala. Oh my god, all of you are correct. Right. Very good. Amazing. So it is kwashiorkor. We know malnutrition with edema is kwashiorkor. Moving ahead, a child's height for age is between -2 to -3 Z score. The child will be classified under which of the categories? So is it wasting or normal or stunting or severe acute malnutrition? Yes. What is the answer? So height for age between -2 to -3 Z score. Quick, quick, quick. These are the questions where you don't need to think much. If you know the answer, you know it. So what is it called? Height for age. So see, it is height for age between -2 to -3 Z score. What is it called? Okay, Ankit, Akhtar, okay, Bhartendu, invisible. Okay, you are indeed invisible. Yashti, Kunal Bhati, Rachna, Kabir, Thor. Okay, so whenever we are talking about height, okay, it cannot be wasting, right? It has to be stunting. So if the height is between -2 to -3 Z score, it is called stunting. And if it is less than -3 Z score, it is called severe stunting, right? And it is, this stunting or a decrease in height for age is an indicator of chronic malnutrition, while decrease in weight for height or wasting is an indicator of acute malnutrition. Okay, right. This condition, you can see a child, this is a malnourished child with edema. You can see the distended abdomen and edema is there. So this condition seen in this child could be due to which of the following? Kwashiorkor due to less protein and calorie intake, kwashiorkor due to less calorie intake, marasmus due to low protein and calorie intake, and marasmus with low calorie intake. Very good. So the answer is A. Pavan, Vikrant, Vishal, Ranveer, Madhumita, Ramesh, Vinay, Rain, Hansala, Nupur, Shashi, Aditya, Kani, Dr. World, Shifali. Very good. So yes, this is kwashiorkor due to less protein and calorie intake. We all know if hypoalbuminemia is also there, then edema will be there. Okay, so kwashiorkor is due to both less protein and less calorie intake because edema is also seen. For severe acute malnutrition, mid-arm circumference should be less than. Yes, very, very important. Severe acute malnutrition, mid-arm circumference should be less than. Waiting for your answers. 14.5 centimeter, 13.5, 12.5, 11.5. Yes, very good. Aditya, Rajendra, Rain, Strange, Karishma, Berlin, Shashi, Benazir, Sarika, Adrenaline, Akhtar. Very good. So it is 11.5 centimeters. And what is the device which is used by the health workers to measure the mid-arm circumference? Anyone? So device used by to health workers to measure the mid-arm circumference. So it is a measuring tape with 3 colored zones, red, yellow and green. Yes, who can give me the answer? The name of the device used to measure mid-arm circumference by the health workers. So that is known as, very good, Revati, Nupur, Ashwin, okay, Aryan. Yes, so it is Shakir's tape. It is not Harpenden calipers, dear. Harpenden calipers is used to measure the skin fold thickness, but mid-arm circumference we use Shakir's tape, right? So moving ahead, a little bit about micronutrient deficiency. You have to know about, iron deficiency, a little bit about rickets is important. Do read up. Vitamin A deficiency, again, a very important topic. We all know there's a WHO grading of vitamin A deficiency. So X is for xerophthalmia and XN is night blindness. And night blindness, is the first symptom of vitamin A deficiency, while the first sign of vitamin A deficiency is conjunctival xerosis. Okay. Then you have X1B, that is Bitot spot. What happens in Bitot spot is, triangular areas are there on the conjunctiva. Triangular areas are there like this. So this is the cornea and the triangular areas are there. Whitish, pearly white deposits. X2 is corneal xerosis. X3A and 3B are corneal ulceration, and XS is finally corneal scar. Okay. So treatment of vitamin A deficiency, the dosages are very important. Multiple times they have been asked. Less than 6 months of age, per dose would be 50,000 international units. 6 to 12 months, 1 lakh international units. And more than 1 year, the dose would be 2 lakh international units. And if you want to give a therapeutic dose, that means the child already has signs and symptoms of vitamin A deficiency, you have to repeat the dose next day and 4 weeks later. So 3 doses are required. And if you want to give the dose parenterally, half of the oral dose, right? Now, moving on to a question, pearly white lesions with foamy appearance are seen on the sclera of a child. Which of the following other symptoms related to the deficiency of the same micronutrient causing the mentioned lesion? So, you can see pearly white lesions with foamy appearance involving the area over the sclera. So, that probably indicates Bitot spots, which is a symptom of vitamin A deficiency, which is a sign of rather vitamin A deficiency. So, which of these would be the correct answer? Ramesh, Sarika, Karishma, Rahul, Kiran, Akhtar, Rachna, Priyanka, Dharamveer, MS, Rose, Abhishek, Pavan, Strange, Vinay. Very good. So, it is A, or conjunctival cirrhosis. We know conjunctival cirrhosis is one of the signs of vitamin A deficiency, right? And not angular stomatitis, glossitis, photosensitive rash. Okay, so angular stomatitis and glossitis more in riboflavin deficiency. Oral vitamin A dosage in a 2-year-old malnourished child weighing 10 kgs is. Yes, so oral vitamin A dosage in a 2-year-old child, we know 2-year-old child, so age more than 1 year, what would be the dose of vitamin A? Come on, dose of vitamin A, very important in a child more than 1 year of age, per dose would be. Very good, Nida, Alia, Aditya, Karishma, Dharamveer, Ashish, Vishal. So it will be 2 lakh units. Right. So moving ahead from genetics, we need to remember the modes of inheritance of some very important disorders. Okay, there are a lot of mnemonics, so you can use any of them. So like for important autosomal dominant disorders, we know dominant disorders are those where one of the parents are also usually affected, right? So heavy dominant is the mnemonic that you can use. H for hereditary spherocytosis, D for dystrophia myotonica. Dystrophia myotonica, of course, also is a trinucleotide repeat disorder, so not typically Mendelian also. O for osteogenesis imperfecta. Most of the types of osteogenesis imperfecta have autosomal dominant inheritance. Okay. M for Marfan syndrome, I for intermittent porphyria, N for neurofibromatosis. So remember, neurofibromatosis and tuberous sclerosis are two very, very important examples of, this autosomal dominant inheritance. A for achondroplasia, where you get a short stature, champagne glass pelvis, trident hand, and so on. ADPKD, autosomal dominant polycystic kidney disease, Noonan syndrome. So all these are examples of autosomal dominant diseases. Okay. Now, important autosomal recessive disorders, you can remember A, B, C, D, E, F, G, H, I. So, A for albinism, alkaptonuria. So, most of the metabolic disorders, remember, inborn errors of metabolism, most of them are autosomal recessive. There are a few exceptions like, Hunter disease and Fabry disease. Okay. So, B for beta thalassemia, sickle cell anemia. Okay, C for cystic fibrosis, CAH or congenital adrenal hyperplasia, D for most of the forms of deafness, E for emphysema due to alpha-1 antitrypsin deficiency, F for Friedreich's ataxia, G for Gaucher and galactosemia, H for homocystinuria, and I for inborn errors of metabolism. Most of them, except we said, so except Hunter's disease, okay, which has X-linked recessive inheritance, and Fabry disease, okay. Except them, most of them are having, this autosomal recessive inheritance, right? Now, diseases with X-linked recessive inheritance, you can remember by a mnemonic, girls do care for chawal. Okay, they don't want to eat a lot of rice usually. So that is the mnemonic. So G for G6PD deficiency, glucose 6-phosphate dehydrogenase deficiency. D for Duchenne muscular dystrophy and Becker muscular dystrophy also, which is the milder form of the same disease. C for color blindness. F for Fragile X syndrome and Fabry disease. C for chronic granulomatous disease, where what is the test used for CGT? So it is NBT, nitroblue tetrazolium test is the screening test, and the confirmatory test is dihydrorhodamine assay. H for hemophilia A and B and Hunter disease. A for gamma globulinemia, it is also called Bruton's A gamma globulinemia. W for Wiskott-Aldrich syndrome. Wiskott-Aldrich again is an important disorder where you get thrombocytopenia. Okay, thrombocytopenia is there, because of which bleeding manifestations are going to be there. There's a atopic dermatitis like rash is there, and recurrent infections because there's immunodeficiency. Okay, atopic dermatitis like rash is there, and recurrent infections are there, right? Because of thrombocytopenia, you get bleeding manifestations. A for albinism, L for Lesch-Nyhan syndrome, and Loeys syndrome, right? Moving on to some examples of X-linked dominant disorders, red rose for all children. So R for X-linked hypophosphatemic rickets. What is the gene involved? Hypophosphatemic rickets, PHEX, FEX gene. R for Rett syndrome. Rett syndrome again is a typical example of X-linked dominant inheritance. Okay, very few disorders of X-linked dominant inheritance. F for Fragile X, A for Alport, and C for Charcot-Marie Tooth disease. Now, how to interpret pedigree? We all know, very, very important. First, see if all the children of a mother are affected, then it is mitochondrial inheritance. Okay. If at least one parent has the disorder, then it is dominant disease. If father to son transmission is not occurring, that means it is X-linked, because father's Y chromosome goes to the son, X chromosome never goes. So if father to son transmission of the trait is not occurring, then it is X-linked disorder. Okay, so these are some basic rules using which you can solve any pedigree, right? Down syndrome, we know, is the most common chromosomal abnormality seen in children, and 95% cases are due to non-disjunction, 3% cases are due to translocation, and 1 to 2% mosaicism are there. And what is the typical? So this investigation, if you are asked what is this investigation, this is a karyotype where you can see all the chromosomes. And what do you see here? You see 3 copies of chromosome 21 here. So this is trisomy 21 or Down syndrome. Okay, very important image-based question that can come. And you can see, so the number of chromosomes, if you count here total, it is 47 instead of the normal 46. And there are 2 X chromosomes, no Y chromosome. So it is 47 XX and plus 21. Chromosome 21, 1 extra copy is there. And because it is XX, it is a girl. So it is a girl with Down syndrome, right? Turner syndrome, you can remember the important features by mnemonic. C, there is a baby clown. So C, S for short stature, sensory neural hearing loss, and short fourth metacarpal is there. Then A for amenorrhea, there's a primary amenorrhea. These individuals never attain menarche because they have streak ovaries and rudimentary uterus. Baby clown, B for bar body absent. We all know the number of bar bodies is number of X chromosomes minus 1. So in females, normally 2 X chromosomes are there, so 1 bar body. But Turner syndrome, they are females with 1 X chromosome. The karyotype in Turner syndrome we know is 45XO. So they do not have a Y chromosome, they have only 1 X chromosome. So Turner syndrome always seen in females, and the number of bar bodies in Turner syndrome is how many X chromosomes? 1. So number of bar bodies will be 1 minus 1, that is 0. So if you are getting a female with absent bar body, think of Turner syndrome. Then C for cardiac anomaly, C for cystic hygroma, L for lymphedema, low thyroid or hypothyroidism, O for ovaries underdeveloped, W for webbed neck or loose skin folds around the neck area, N for nipples widely spaced, right? So Noonan is a similar disorder. Some clinical features are similar, but remember Noonan can be seen in either boys or girls, and Noonan usually has an autosomal dominant inheritance, and the karyotype picture is normal in Noonan disease, okay? Which of the following has autosomal recessive inheritance? Now very easy for you now. Tell me which of the following has autosomal recessive inheritance. Is it hereditary spherocytosis, sickle cell anemia, osteogenesis imperfecta, or von Willebrand disease? Yes, waiting for your answers. Which of the following has autosomal recessive inheritance? Come on, quick. So, very good. Dr. Rain, Dr. Niyati, Debopam Datta, Vinay Yadav. So it is sickle cell anemia. Okay, it has autosomal recessive inheritance. Hereditary spherocytosis we know has autosomal dominant inheritance. Osteogenesis imperfecta also, and von Willebrand disease also. Most of them have autosomal dominant inheritance. Okay, very good. So which of the following is an autosomal dominant disease? Is it von Willebrand disease, Wilson disease, cystic fibrosis, Friedreich's ataxia? So which of these is the autosomal dominant disorder? Waiting for your answers. Autosomal dominant disorder. Yes, which of these is the autosomal dominant disorder? So Revati, Nupur, HP, Debopam, medical doctor Vinay, Ujwala. Yes. So von Willebrand disease has autosomal dominant inheritance. Wilson disease has got autosomal recessive inheritance. ATP7B gene is involved. And cystic fibrosis again autosomal recessive inheritance. Wilson disease also autosomal recessive inheritance. Cystic fibrosis autosomal recessive inheritance. CFTR gene is involved, and Friedreich's ataxia is a trinucleotide repeat disorder. So von Willebrand disease is the best answer. A 16-year-old girl presents with short height, short stitches there, primary amenorrhea, widely spaced nipples. Her probable karyotype is. So this is a case scenario, friends, of which syndrome? So it appears, so there is a short stature, primary amenorrhea, never attained menorrhea, never attained menarche, and widely spaced nipples. So this is a example of, this is a case scenario of Turner syndrome, right? So what will be the karyotype here? So Benazir, Mrunali, Akansha, Priyanka, Rose, Devraj, very good. Karishma, Dr. Madhumita, Harshit, right. So it is, the karyotype is going to be 45X. So that means 45 chromosomes will be there instead of 46, and 1 X chromosome, no Y chromosome, right? Now moving ahead to quickly a little bit about some inborn errors of metabolism. So the important ones which you should be aware of are phenylketonuria, where the enzyme deficient we know is phenylalanine hydroxylase. Okay, phenylalanine hydroxylase. So what happens because of this enzyme deficient? what will happen? So phenylalanine will not get converted to tyrosine. So tyrosine will become an essential amino acid. Because tyrosine is not formed, dopa is not formed, melanin is not formed. So there is hypopigmentation in these individuals. So they have fair skin, blonde hair. So hypopigmented individuals are there. They have some neurological features because of the accumulation of phenylalanine and its metabolites. There can be intellectual disability, there can be, spasticity, seizures, and so on. So neurological features are there, and there can be a typical mousy odor of the urine or body fluids. Okay. Alkaptonuria, very, very important, has been asked multiple times in various case scenarios. Urine turns black on standing in alkaptonuria. So urine turns black on standing. So that is the only manifestation that you see in children. Okay. So mother will complain that the diaper becomes black. Okay. And when the individuals grow up, they can have ochronosis, which are black spots on the sclera or the ear cartilage, and they can have arthritis and some cardiac problems also. What is the enzyme deficient? Yes, waiting for your answers. Very good, dear. So Revati, very good. MS, right? So it is homogenticate oxidase. So either homogentisic acid oxidase you can call it, or you can call it homogenticate oxidase. Okay. Right. Now galactosemia. Galactosemia is a disorder which can be caused by the deficiency of any of the three enzymes. What are they? So they are, galactosemia, tell me. So it can either be GALT, that means galactose 1-phosphate uridyl transferase, or galactokinase or epimerase. So any of these three enzymes, if they are deficient, they can cause galactosemia. Okay. And what are the manifestations that you get? So you get hepatic dysfunction. Okay. Hepatic dysfunction can be there. So there can be jaundice and diarrhea, vomiting can be there. Cataracts, so typically oil drop cataract. I saw some of you wrote in the chat box also, very good. So oil drop cataracts can be seen. Okay. So this hepatic dysfunction, jaundice, vomiting, diarrhea, oil drop cataracts. So these are the usual manifestations that you get in galactosemia. Von-Guericke disease is due to deficiency of which enzyme? So Von-Guericke disease is due to deficiency of the enzyme glucose 6-phosphatase, where the body is not able to convert glucose 6-phosphate into glucose. So there will be hypoglycemia. Okay. And along with hypoglycemia, there is hyperlipidemia. Okay. Hyperlipidemia is there, and the baby has doll-like faces, and there can be case scenario where you're getting early morning hypoglycemia, early morning lethargy, and seizures can be there. Okay. So that is typically what you get in Von-Guericke. And huge hepatomegaly. So this is a type of glycogen storage disorder. So huge hepatomegaly and abdominal distension is there. Uric acid levels are also elevated. Okay. Gaucher disease, what is the enzyme deficiency? So each of these disorders that we are discussing here are very, very important and are individual questions by themselves. So these are must know inborn errors of metabolism for you. Right. So Gaucher disease, very good. So the enzyme deficient is glucocerebrosidase. Okay. Glucocerebrosidase. So there is accumulation of glucocerebrosides in some of the cells, like the cells of the bone marrow, cells of the reticuloendothelial system. So you get what are known as Gaucher cells in bone marrow. Okay, sometimes in peripheral blood also. And because these Gaucher cells are infiltrating everywhere, you get splenohepatomegaly. It is one of the causes of massive splenomegaly. Okay, the spleen becomes so huge it almost fills the entire abdomen of the baby. So splenohepatomegaly, and there is pancytopenia because of the infiltration in bone marrow by the Gaucher cells. Pancytopenia is there. So there is anemia, requirement of recurrent blood transfusions, thrombocytopenia leading to bleeding manifestations, and leukopenia leading to recurrent infections. And plus there can be bone pains and pathological fractures and so on. Lesch-Nyhan syndrome, we said, has X-linked recessive inheritance. Okay, is one of the very few metabolic disorders like Fabry or Hunter which has X-linked recessive inheritance. And the enzyme deficient is HGPRT, hypoxanthine guanine phosphoribosyl transferase. Okay, and this disorder is where the children are normal at birth, but eventually they will develop developmental delay. A very important feature, as one of you mentioned in the chat box, is self-mutilation. Okay, these individuals will harm themselves, cause injury to themselves. So self-mutilation is there, and they have elevated uric acid levels. Okay, which is diagnostic. Right. So these are some very, very important metabolic disorders. There are certain inborn errors of metabolism with peculiar odor, like glutaric acidemia. You can get a sweaty feet odor. Okay, sweaty feet odor. Maple syrup urine disease, you can get a maple syrup like or a burnt sugar odor. Okay, burnt sugar odor. Tyrosinemia, you get a boiled cabbage odor. Okay, and then multiple carboxylase deficiency, I really don't know what it is, but it is a tomcat urine odor which is said. Phenylketonuria, you get a mousy or a musty body odor. Okay, right. So moving ahead to a case scenario, a child is brought to the OPD with the complaint of change in color of urine after some time. Mother gives a history that she noticed a dark black color on the diaper when her baby was few months old. Which enzyme deficiency is present in the given patient? So friends, we all know what is the disorder that we are dealing with. So we are dealing with alkaptonuria here. Yes, so you have answered already. Nupur, Satish, Pavan, MS, Dharamveer, Guevara, Kenny, Dr. Niyati, Gajendra, Vamil, Nikhil, Khalid, Mrinali. Very good. So it is, indeed alkaptonuria, and the enzyme deficient we know as homogentic acid oxidase, right? A child with hypoglycemia was found to have burnt sugar urine odor. So hypoglycemia is there, burnt sugar urine odor is there. Which disorder are we thinking of? We are thinking of maple syrup urine disease. And this is a problem in the metabolism of branch chain amino acids in this disorder. Which are the branch chain amino acids? Isoleucine, leucine and valine. So what is the best answer? So very good. Guevala, Shaleen, Avinash, Revati, Meghna, Debupam, Gajender, Umar, Mridali, Nupur, Alia, Lokesh, Pooja, Shashi. Very good. So it is branch chain alpha acid ketodehydrogenase which is deficient here. So the branch chain amino acids are not getting metabolized. Which enzyme is deficient in Lesch-Nyhan syndrome? We already discussed. So the enzyme deficient in Lesch-Nyhan syndrome is, come on, Fuzel, Vikrant, Madhumita, Subhash, Guevara, Hanzala, Amritash, Niyati. Very good. So it is the HGPRT, hypoxanthine guanine phosphoribosyl transferase, right? A 2-year-old girl presented with a history of recurrent episodes of early morning lethargy and seizures. On examination, the child had doll-like faces and hepatomegaly. So there is, early morning lethargy and seizures, doll-like faces, hepatomegaly. Investigations revealed the presence of hypoglycemia, elevated lactic acid levels, and hyperlipidemia. Which enzyme is deficient? So here, what is the disease that we are dealing with? So I'm sure you're able to make out we are dealing with type 1 glycogen storage disorder or Von-Guericke disease. And we all know what is the enzyme deficient in Von-Guericke disease. Yes, waiting for your answers. So Ramesh, Vishnu, Pushpendra, Nikhil, Asiya, Apollo, Shantani, Pavan, Kiran, Shatrupa, Akiraj. Very good. So it is glucose 6 phosphatase which is deficient here. Okay. Muscle phospholipase we know is deficient in McArdle disease. Okay. And hepatic phosphorylase in Hers disease. G6PD we already discussed. So a child presented with palpable rash on limb. So you can see a palpable rash on limb is there. Hematuria, that means kidney involvement, and joint pain, that means joint involvement is also there. Arthritis, arthralgia. There was a history of respiratory infection 1 week ago. What is the probable diagnosis? So is it Henoch-Schönlein purpura, rheumatoid arthritis? Is it hemolytic uremic syndrome or reactive arthritis? Yes. Ashish, Alia, Surya, Vijay, Satrupa, Akansha, Rachna, Unnati, very good. Subhash. So it is Henoch-Schönlein purpura. So Henoch-Schönlein purpura, we know the diagnostic criteria is palpable purpura, and it is mainly present over the buttocks and the lower limbs mainly, but it can be there in upper limbs also. Okay, so palpable purpura with presence of any one of the following. So either arthritis, arthralgia is there. So arthritis, arthralgia is there, or or there is presence of abdominal pain, or there is kidney involvement in any form, like kidney involvement in the form of hematuria, proteinuria and so on, and presence of IgA in any biopsy sample, skin biopsy, kidney biopsy, any biopsy sample. So if any one of these along with palpable purpura, it is Henoch-Schönlein purpura. And remember, even though purpura is there, but thrombocytopenia is absent in Henoch-Schönlein purpura. So that is also asked multiple times in the question. Thrombocytopenia is absent. So which of the following is not seen in HSP is often asked, right? So a little bit about infectious diseases. So measles, we know measles you typically get a erythematous maculopapular rash which starts from behind the ear, spreads to rest of the body. So erythematous maculopapular confluent rash which merges with each other, and when it disappears also it leaves behind a pigmentation. Okay. And apart from that, there is presence of Koplik spots in measles. So Koplik spots are some spots which are found on the mucosa, on the buccal mucosa, on the conjunctiva also it can be there, in the vaginal mucosa also it can be there. So bluish white center and erythematous periphery, Koplik spots are there which are there. Apart from that, in measles the child has a wet look, so there's a lot of coryza or running nose, and conjunctivitis is also associated. Okay. Chicken pox, what happens? Chicken pox is typically along with fever, usually the rash which is there is pleomorphic. That means multiple types of rash are present at the same time. So you can see a macule also, papules also, vesicles also, pustules also, and sometimes scarring and all can also be there. So pleomorphic skin rash is what you typically get in chicken pox, right? Mumps, what will you get? So mumps, you get fever and you get parotid swelling, which can be either unilateral or bilateral. It is a very infectious disease. So you can get a parotid swelling, which can be unilateral or bilateral, and there can be, orchitis. In males, there can be orchitis. And aseptic meningitis is a very important complication. Okay. Speaking of complications, a very important long-term complication of measles is something known as SSPE, subacute sclerosing panencephalitis, which is a fatal complication of measles, which is also often asked. Okay. Erythema infectiosum is caused by parvovirus, and we know typically the rash that you get in erythema infectiosum, we can get a image-based question also. It is called a slap cheek appearance of rash. Okay, slap cheek appearance of rash, and there is this low-grade fever and viral prodrome and so on. Right. So, Koplik spots are seen in mumps, measles, rubella, varicella. What is the answer? Waiting for your answers. Come on, quick. Koplik spots are seen in. Come on. So, the answer is yes. Dr. Niyati again. Priyanka, Satish, Akshat, medical doctor, Ujjwala, Subhash, Kunal, Bijal, Amitash. Okay. Surya. So it is measles, right? So we said they are seen in mucosa. They can be seen on buccal mucosa mainly. Apart from that, conjunctiva and vagina also. Subacute sclerosing panencephalitis is a rare and dangerous complication of again measles, mumps, rubella, varicella. Yes, what is the answer? So SSP, we said, is a condition where the child will have there will be loss of previously attained milestones. There will be myoclonic jerks, and which other condition you get myoclonic jerks? You also get myoclonic jerks or infantile spasms in West syndrome, right? So SSP is a condition which is a complication of very good. So Fuzel, Unnati, Dhruvi, Akansha, Wandering Hill, Pavan, Nigar, Ashish. So measles, okay, it is a complication, dreadful complication of measles, but it happens long term. I mean, almost 10 years later. Okay. So a male child presents to you with swelling below the ear along with low-grade fever. There have been two other similar cases. That means it is an infectious disease. So swelling below the ear in the parotid area, low-grade fever is there. Two other similar cases in the friends of the child in the same village. What will you do? So what is the disease first? What do you think is the disease that we are dealing with? And what will you do? Whether it will be immediate hospitalization or incision and drainage of the swelling or mouthwash or give antipyretics and send home. Yes, so we are dealing with a case of mumps and you need not do much about it. It will subside spontaneously. It is a viral illness. So the best answer, very good, which most of you have said, Sanjay, Anna, Shreya, Akhiraj, medical doctor, Sashi Bhushan, Suman, very good guys. So it is give antipyretics and send home. It is a case of mumps, right? A boy presents with features of shock and cold, clammy skin. The next step in management is, so if a child is having shock, the first thing that you will do is secure, you will see the ABC, airway, breathing, circulation, disability, exposure, all that you'll do like you do in a medical emergency, and you will secure wide bore intravenous access, and you will give fluid boluses. So what is the fluid of choice that is used in shock in children? Yes, so waiting for your answer. Very good. Khalid, Aditya, Satya, Dr. Rain, Harshit. Right, very good. So what will you do? So the fluid boluses will be of normal saline. Okay, normal saline is the fluid of choice for managing shock in children. So you give multiple 3 fluid boluses, and after that you move on to give catecholamines. Okay, and if it is a catecholamine refractory shock, even steroids may be required. And of course, if you're suspecting septic shock, broad spectrum IV antibiotics also to be started. Now moving on to immunization, national immunization schedule, very very important. The latest updated national immunization schedule. At birth, which vaccines are to be given? I'm sure all of you know them. So they are the BCG, the oral polio vaccine 0 dose, and hepatitis B birth dose. These are the 3 vaccines, very very important, which must be given at birth to all the babies. Okay. So hepatitis B birth dose is very important in preventing mother to child transmission of hepatitis B if at all the mother is hepatitis B positive. So it should be given as soon as possible after delivery. Okay. At 6 weeks, what all is to be given? So OPV 1, rotavirus 1, pentavalent 1, fractional IPV first dose, pneumococcal conjugate vaccine first dose. So these 5 vaccines are recommended to be given at 6 weeks. At 10 weeks, OPV 2, rotavirus 2 and pentavalent 2. Second dose of OPV, rotavirus and pentavalent. 14 weeks, OPV third dose, rotavirus third dose, pentavalent third dose, fractional IPV second dose and pneumococcal vaccine second dose. Okay, right? 9 to 12 months, measles and rubella vaccine first dose, PCV booster, so pneumococcal conjugate vaccine booster, and Japanese encephalitis in endemic districts. So there's a latest update. okay, which we've already mentioned on our Insta and other handles. So an additional dose of fractional IPV at 9 months of age has been introduced from this 1st January 2023, right? So this is a very important upcoming question that can be there. So an additional dose of fractional IPV is now recommended to be given at 9 months of age along with your measles and rubella vaccine and the PCV booster. So one more dose of fractional IPV has been added here. And this is the latest update in the National Immunization Schedule, right? 16 to 24 months, again, measles, rubella second dose, DPT booster, OPV booster, Japanese encephalitis second dose in endemic districts. 5 to 6 years, DPT booster 2, and 10 years and 16 years, TD, the tetanus and adult diphtheria. So that is the National Immunization Schedule, okay, the latest one. So, quick questions. Which vaccines are given at birth? So, IPV birth dose, hepatitis B birth dose, DPT birth dose, BCG, Hep B birth dose, MR birth dose, BCG, Hep B birth dose, DPT birth dose, BCG, OPV birth dose, Hep B birth dose. So which vaccines are given at birth? Very, very important must know area. No mistake permissible here. Right? I want correct answer from all of you. Come on. Very good. So Ashish, Revati, Shade, MS, Vinay, Gajendra, Shashi, Rain, Shalin, Ujwala, Dolly. Very good, guys. So BCG, OPV birth dose and hepatitis birth dose are the vaccines given at birth. Which of the following vaccines is recommended as at birth? Again, measles, Japanese encephalitis, BCG, vitamin A. So measles we know is recommended. The first dose is recommended around 9 months of age, right? In the form of measles rubella vaccine. Japanese encephalitis to be given in the endemic districts only. BCG, vitamin A. So vitamin A we know is not a vaccine also, and it is not given at birth, of course. So the best answer here is C, BCG. Okay. So BCG gives 0 to 80% protection against the severe forms of tuberculosis, right? So first dose of measles vaccine was given on 7 month of age due to some reason. Probably it was an epidemic going on, and the first dose of measles vaccine, if it has been given at 7 months of age. But we know measles vaccine in the National Immunization Schedule is recommended around 9 months of age, 9 completed months of age. So when will you schedule the child for next dose? So next dose at 16 to 24 months, or B, first dose at 9 months and next at 16 to 24 months, C, no dose at 9 months, D, booster at 9 months. What will you do? So if at all you have to give a measles vaccine dose before 9 months of age due to any reason, remember that dose is not counted. So most of you know the answer. Rohit, Kiran, Rain, Dharmveer, Mano, Shashi, Aditya, very good. Doctor in White, nice name. So first dose at 9 months and next at 16 to 24, you still have to give. So this dose at 7 months will not be counted, right? So that's the best answer. Moving ahead, hepatitis B vaccine should be given at, we know it is given at birth, and then 3 months, 6 months is usually 1 year is not what is recommended. In the National Immunization Schedule, it is recommended at birth, then 6, 10 and 14 weeks as a part of the pentavalent vaccine, right? Now, management of an infant born to hepatitis B positive mother, we already said that the birth dose of hepatitis B vaccine goes a long way in protecting the baby from, hepatitis B. So if the mother is HBsAg positive, baby should be given hepatitis B immunoglobulin along with the hepatitis B vaccine, and it should ideally be given within 12 hours of birth at 2 different sites, okay, if the mother is HBsAg positive. But hepatitis B immunoglobulin should be given within 12 hours after birth. But as if you have not given in 12 hours, you can give it up to 7 days of birth. Okay. And 3 more doses of hepatitis B should be administered at 6, 10 and 14 weeks. If mother's HBsAg status is not known, you will still give the hepatitis B vaccination birth dose. And if you give the vaccine alone at birth, it gives a protective efficacy of 70 to 75%. And if you give it along with immunoglobulins, it gives an efficacy of 85 to 95%. Okay. Now, so a primary gravida patient came to hospital without any antenatal checkup at 37 weeks of gestation, almost term, and presented with onset of labor. On investigation, the mother is hepatitis B positive. What management should be given to the neonate? Yes. So what do you think? A, hepatitis B vaccine only. B, hepatitis B vaccine plus immunoglobulin. C, first immunoglobulin, then hepatitis B vaccine after 1 month. D, only immunoglobulin. So what will be your answer? Very good. So you all are awake. That means very good. So I'm impressed. Nupur, Rupesh, Siddharth, Madhumita, Ramesh, Ashish, Dr. VK, Priyanka, Aditya, Manu, Debopam. Very good. Right? So hepatitis B vaccine plus immunoglobulin, both of them you'll give within 12 hours after birth at 2 different sites using 2 different syringes. Okay? So we'll do that. Now what about this open vial policy? So what is this open vial policy? So this open vial policy promotes the reuse of partially used multi-dose vials. Okay. So if a vial has got 10 doses of vaccine, in a session if you use 4 doses, 6 doses are remaining. For the vaccines that follow the open vial policy, you can store that vaccine and reuse it in subsequent immunization sessions, okay, provided certain conditions are met. So reuse of partially used multi-dose vials of certain vaccines, okay, provided certain conditions are met. So what are the criteria which should be met to follow the open vial policy? Let us see. So points to be checked as per open vial policies: expiry date of the vaccine should not have passed, okay, vaccine should be stored under appropriate cold chain conditions both during transportation and storage, vaccine vial septum should not have been submerged in water or contaminated in any way, and aseptic technique has been used to withdraw the vaccine doses. And the VVM, we know VVM, very important, you get questions from it. So VVM is the vaccine vial monitor, which will tell you whether the proper cold chain has been maintained or not. So vaccine vial monitor should not have reached or crossed the discard point, okay. So if they are followed, then open vial policy is applicable for vaccines like pentavalent vaccine, okay, it is applicable for pentavalent, hepatitis B, okay. So vaccines like these, it is applicable. It is not applicable for freeze dried vaccines like BCG, it is not applicable. Measles, MR, Japanese encephalitis, rotavirus, for these vaccines the open vial policy is not applicable, right, but it is applicable for rest of the vaccines, okay. So remember, open vial policy is not applicable for freeze dried vaccines like BCG, measles, MR, JE and rotavirus vaccine also it is not applicable. For rest of the vaccines, so for the vaccines where this vaccine vial monitor is there on the label, for them mostly the open vial policy is applicable. But where this VVM is there on the septum or on the cap, for those vaccines, remember, the open vial policy is not applicable, okay. So we all know vaccine vial monitor looks like this. So if the inner square is lighter in color as compared to the outer circle, you can use the vaccine, okay. But if it is of the same color, if the inner square is of the same color or darker in color, you cannot use the vaccine. So this is the vaccine vial monitor, and its interpretation, very, very important, has been asked a number of times in various questions, okay. So moving ahead, 2 open vials of pentavalent vaccine and 1 open vial of MMR vaccine is given back after an immunization session. So you have 2 open vials of pentavalent vaccine and 1 open vial of MMR vaccine given back after an immunization session. What should be done with those vials? Whether both should be discarded, or pentavalent can be used and MMR should be discarded, or MMR can be used and pentavalent should be discarded, both vials can be reused. So here again our knowledge of open vial policy and which vaccines follow this open vial policy comes to use. Yes, so very good, all of you are correct. Alia, Satish, Bijal, Siddharth, K.R. Prakash, Mustaq, Aditya, Shashi, Suman, Fuzail, Ashwin, Amritansh, Rachna, very, very good. So pentavalent can be used and MMR must be discarded, because we know MMR does not follow the open vial policy, but pentavalent does follow the open vial policy. So which vaccine doesn't follow the open vial policy out of these? BCG, OPV, pentavalent, hepatitis B. Again, an easy question. So we know which of the following vaccines does not follow the open vial policy. So you can pick your answer. Nupur, very good. So your quick, fastest finger first. So Shashi, Dr. Rain, Satish, Harshit, Gajendra, very good. So BCG we know does not follow the open vial policy, while the oral polio vaccine, pentavalent, hepatitis B, they all follow the open vial policy, right? So these, friends, were some of the very, very important topics from general pediatrics which are must know for your upcoming FMG exams. So stay tuned. Tomorrow again we'll come back with some important topics from neonatology and systemic pediatrics. The link for that is there in the description of this video. And do share your feedback, and I'm sure you'll come up with flying colors in your upcoming exams. So keep revising these important topics, and I'm sure you'll not make any mistake in them now, right? So all the very best, study hard, and let's meet again tomorrow, right?